Barry, how you doing? I haven't seen you for a while.
Mark, we meet again. Do you remember us doing these podcasts years ago?
Oh my gosh, that was wow. That was so long ago. Oh, we had the Spreecast, right? This was probably 12 years or so ago. People probably don't even remember what Spreecast was. Actually is the precursor to Zoom,
Yeah.
and it was an alternative to you know podcasts, and the podcast came from the iPod
It-
from Apple, right? Yeah.
we were ahead of our time there. We had people
Yeah.
like Kevin Boyd and John Mew, and we had Bill Hang on those early years.
Yeah,
It
we
was,
we we started off with a theme thinking airway facial development collaborative, and we started off thinking that it was going to be 25 episodes, and I think 85 episodes later, we realized, and our following was a global following. We had people from all over the world. We had guests from all over the world, from
yeah,
medicine, dentistry, allied health, and those were the days. But here we are in our Airway Nexus
yeah.
podcast. And I'm so excited that we picked up the mantle, and Richard's joined us as a very respected educator, and as he said, uh, this whole paradigm's really even changed how he teaches his courses in restorative dentistry, which really resonates with me because I argue that an airway focused dental approach is not a specialty of dentistry. And people want to make it that, just like they did with sleep medicine. I was
Yeah.
turned off by that, to be honest. Dental sleep medicine, it's quote unquote a specialty. It's not recognized. But I didn't want to bottleneck it. I didn't want to make it about sleep. It was really about breathing. And I think there's been a change in that thinking. But this is just a way, regardless of your specialty, of how to
Way of
think about
practicing dentistry
exactly. So it's
and
general,
medicine, frankly.
yes,
Yeah.
it's general dentistry, it's orthodontics, it's periodontics, et cetera, et cetera. So we just are looking more at the patient attached to the teeth, aren't
Yeah.
we? So
It follows the holistic functional medicine approach that I see happening in many specialties. Even physicians, dermatologists are starting to say, what is it about my work that is so limited to treating symptoms? Where are these things coming from? This is stuff that, you surmise, but you don't really look for. Casey Means, we listened to those podcasts about her getting out of her ENT residency saying ENT surgery is eliminating symptoms, but it's not nearly addressing the root cause. And we're discovering the same thing with orthodontics and dentistry. And you know what's funny, Mark? The teeth become less and less important the more I practice. They're the sideshow. They're the canary in the coal mine.
well, that's one way of looking at it. I see it parts of a complex system. And again, when we're siloed, we try to break things down into its parts, but we know that there's a synergy and the body doesn't work that way. And I need to just say, to clarify, when you say holistic, I want to be very clear. I spell it WH, not HO,
Yeah,
because there's holistic, it kind of connotes to some that it's kind of like an alternative, like there's no evidence. It's kind of like very
yeah.
ethereal, and so I always like to um, focus more on the whole body,
The whole, yeah,
a global view of the organism using bioregulatory systems medicine that
right.
really looks at the individual at three levels: at the cellular level, biochemical and cellular level, tissue level, and an organ level, right? So
And the whole is more than the sum of its parts.
exactly, one plus one
Yeah,
equals three. The other thing is I'm going to say, is you had mentioned about um, Casey Means and as an ENT and getting into surgery. You mentioned that last podcast as well. But I remember having this conversation with Suruj Zaghi, who was early on one of the people who come into our mini residency, and he'd just gotten out, and it resonated with him, and he was given a hard time by
Right.
even his faculty at Stanford when he was just focusing on tongue ties. But one of the things that we joked around about, he, Colin, we talk a little bit about it. And he'd say, yeah, there's this conference, otolaryngology conference. I'm not going to go to it. And he sent me the schedule. And he said, it's like here's a whole day dedicated to different flap designs for the U triple P, right? It was very surgical, a better way of doing the wrong thing, in the
Yeah.
end. And that's what happens. Sometimes we overtreat the wrong problem and don't look upstream to root cause and etiology. So that's what
Yeah,
this
that's right.
Airway Nexus podcast is all about, is really getting into that thinking. It's not to throw anyone under the bus because we're all in a system that we've been trained under that has a specific orthodoxy, if you will, right?
It
And
sure
what we're
does.
trying to do is just challenge by asking different questions, not necessarily saying this is the way you've got to do it, but just saying, hey, let's ask some different questions. Let's engage with the patient differently.
Yeah.
And
It is such a different way of thinking. When I signed up for my orthodontic residency, crooked teeth were the problem, braces were the solution. And that's how I was taught. That's how I practiced for nearly 25 years. Once I learned that crooked teeth were a symptom of an imbalance somewhere else in the body, boy, that really changed my thinking. And it's it really takes that change between the ears to see something differently. And once you start to see it, you know this, and we hear it from our students all the time. Once you start to see it, these things have been in front of our faces all this time, and we didn't see them. But once you open your eyes, they're always there.
well, you
Mouth
remember,
breathing, for
yes.
instance.
Well, you remember when we met, at the BioBlock mini residency, we started talking about this.
Right?
It's, when you see something that you never saw before that was hidden in plain sight, you can't unsee it. And that's typically what, our students, if you will, residents that go through will say is, how could I have missed this? And again, it goes back to being blinded by our education, as the saying goes, don't let the education get in the
Yeah.
way of your learning. And there's a lot of pressure because the way you get remunerated, right? The way the third party payer is paying you, especially in medicine, makes it so that these are the rules. Don't look here. This is the way we're going to pay you. And you just don't have time to make that fight, fight that fight. But here we are. And I want to launch into our topic, this podcast, which will be a part two of what you and Richard talked about last podcast last week.
Mhm.
And you gave a really good overview of the theory, if you will.
With
And
Wally.
with the Wally ending with the movie The Wally, and I even told my staff at our morning huddle this last week, I said, you guys watch that movie again, Pixar movie again, with this way of thinking about it, and you'll
Right.
realize how deep that movie is.
Yeah.
It's fun
And
on one end,
scary.
and it really is, but it's totally factual based on what
Yeah.
we already know with big statistics, what's happening globally. I won't go as far as saying existential, although people like Paul Ehrlich at Stanford and others have said that it potentially is existential, and it
I
can
use
get
that
there.
word.
It can be in a different way.
Yeah,
From an economic point of view, like what is talked about in the documentary Escape Fire, where it just becomes unaffordable. Where this is what Casey and Callie Means are trying to
right,
change is that disease management is unsustainable. We're spending so much
right.
time and so, but so let's talk a little bit about um, focusing on pediatrics, and I think in some of our next podcasts we'll talk more about the adult patient, but just to stay a little focused
All right.
on the pediatric population.
Close to my
Um,
heart.
let's talk a little bit about the concepts of an airway focused early intervention philosophy, and I'll just uh, pass it to you to comments, and then I'm going to jump in and kind of define it because as so many people now are jumping in, I'm in, pretty robust disagreement with most of what I'm hearing out there, regardless what they're calling airway. So with that comment, before I go off on it, tell me,
All right.
comment on that.
Well, we had talked about this for years that dentistry had gotten involved in this arena through sleep apnea because we are so good at making appliances, and we had already been using these mandibular protrusion appliances, which just happen not only to bring the mandible forward, but get the tongue out of the throat and so forth. But you and I had seen this pretty quickly that that's really OSA is an end stage disease, right? And there are precursors of it. And once you start understanding the precursors layer by layer, like they say, peeling the onion, it really brings you all the way down to birth. And even, in utero, there are things that are happening that will have these downstream effects. And, some of them do depend upon our genetics, but for the most part, for me, the pendulum has swung towards nurture over nature. To highlight that particular issue that we so often polarize around. Even like the British Dental Service is still prosecuting Michael Mew for saying that crooked teeth are not genetic. They are insisting it's genetic. And I mean, there's so much evidence about how the new environment is affecting us in so many ways. But what ways are they? We often talk about in our work the three domains: structure or anatomy, function or physiology, and
Neurology.
behavior, right? Structure being the size and shape, the contours of the airway, the anatomical parts that maybe create narrow spaces that create turbulence. Function being the physiologic aspects of, oh, I don't know, swelling and mucus and inflammation and immune reaction and all the ways our body seeks to find homeostasis. And then behavior are the things that we do in response to stressful challenges. And certainly because so many parts of our modern environment are novel to our biology, we have to adapt to them somehow. And generally, the behaviors that we pick, while helping us survive and cope with the immediate stress, they will often have their unintended consequences.
Okay, so let me jump in for a second
Sure.
to just qualify before we kind of get to, what do we do about the problem?
Yeah.
So you and I, and I think the great thing is you and I, through the years we see the same thing and maybe describe it a little differently. So I'm going to say the same thing, but I'm going to describe it the way I describe it.
We're
So
going to get into our heated agreements.
the heated agreements,
We're,
yes.
we're very
So the
good
structure we know, that's clear. And
at
any dentist knows that, right? It's the
that.
crossbite, it's the narrow palate, it's the high palate and all that.
Yeah.
That's intellectually low-hanging fruit. That's easy to identify.
Okay.
The
Well,
function. let me just get in.
It sort of, it's easy once you know what to look for.
The function, the function is in neurology. Okay, so we get into the chicken or the egg about what starts first, and in our courses we really get into it starting during ontogeny, especially the third trimester of life, where it's really the neurology. And I want to comment on obstructive sleep apnea as an end stage. I'm going to lead to that by looking at the neurology that is nascent very early on. So neurology is synonymous with function. It's what gives function. Behavior is something that's under our control, but people get really confused about what behavior is. When we're talking about breathing behavior, breathing is the behavior, not to be confused with respiration, which is physiology. Okay, so behavior, how we breathe, will serve us in a certain way, sometimes with unintended consequences. So, um, one of our podcasts has to focus on this whole idea of breathing behavior that is either not recognized for what it is or is misunderstood. So, I'm not going to get any deeper into that because our podcast would go in a different direction.
All right.
With when you say obstructive sleep apnea, you're absolutely right that most people do not understand that it is an end stage diagnosis. And let me explain why, very well validated, is
Okay.
think about it. We do not stop, no mammal stops their breathing for more than 10 seconds, even when they're sleeping, unless there's been a lot of damage to the neurology, to the function. And at that point, you could stop it for a long time and drop the oxygen, the oxygen
Saturation.
saturation drops.
Right.
So that takes a long time to happen, except for the exception with the very, very young, because the neurology is still very nascent. So I'm going to put
Right.
these two populations. So you can have obstructive sleep apnea with very pediatric obstructive sleep apnea, very, very young. We're going to put that as a side. But for the adult that's having that, it's only because they've had chronic intermittent hypoxia through many, many years that causes damage to the cerebellum, to the insula, to the mammillary bodies, to the hippocampus. All the studies looking at changing the relays, if you will, to the brain stem to tell you to take that next breath. So we want to prevent that because um, that same individual that has end stage sleep apnea, they don't stop their breathing during the day because they're consciously aware because they've got enough to override that. So that's pretty scary when you start understanding the consequences of something that may have started decades before that was unrecognized. So that's a huge problem, and why obstructive sleep apnea is well underestimated in the United States. And you have studies like the Hypnoloft study in Lausanne, Switzerland, published in the Lancet 2014, that found that obstructive sleep apnea was almost 50% in males, which was, twice of what is reported in the United States, and three times what's reported in the United States at 27% for females in a much healthier population. So let's just kind of put that aside that it's really about breathing, not sleep. It's just that when we sleep, we lose our
More susceptible.
reflexes and it rears its ugly head. So
Yeah, yeah, yeah.
this is not about sleep. It's about
Now breathing.
breathing.
Right.
So
And that's a fundamental concept. But let's stick to the neurology thing. We're describing downstream damage to central patterns that would protect us and that help us survive moment to moment, right? Breathing's the most important thing we do moment to moment. But there's also neurology that occurs early on in life, not necessarily from damage, but from maldevelopment, let's say, that transition from infantile reflexes which let's, assume for the minute that they work well and they're helping the child survive that first year of life. And then they're supposed to transition into more mature reflexes or more mature behaviors, I should say, as the brain develops and as learning occurs, and the fact that that doesn't always happen in a smooth or complete fashion is also a neurologic issue for a lot of kids. They carry with them these unresolved, or as they say, unintegrated behaviors that interfere with being mature. And on a biologic basis, on an emotional basis, on a cognitive basis, um, is
So
it
let me comment on that just to jump in.
right?
Things
Sure.
again we go over in the Airway mini residence, and why I keep on bringing that up is that I think that we need to as a profession go beyond just a weekend course understanding, a weekend level understanding, a widget level understanding of what Airway is. And for a number of reasons. Number one, it will allow us to see things differently. Number two, to diagnose differently. And three, treatment plan and sequence differently, right? So when you have a deep knowledge of something, it's very different than if you have, a more superficial knowledge that ends up selling a widget, as a solution. So,
Right.
when we talk about the neurology, when the baby is born, goes from fetal respiration to breathing atmospheric air, and it
Uh,
starts with that first
First
scream,
breath.
primal scream,
Yeah.
and then you're born all of a sudden, welcome into the real world, and you're taking in that first inspiration,
Yeah.
and so
Which is an infantile reflex.
yes, and that is a immature neurology
Right.
that has a high risk of what Ron Pei and Jung Pei, or what Ron Harper and Jung Pei and others have written about, called periodic breathing. Very, very common because the neurology has not matured enough yet. And Kristen Gimenoz also talks a lot about this. So you have that initial immature breathing that's periodic. So they're learning, their neurology very rapidly is learning how to breathe. And it starts with nasal breathing always, because you're going to latch right away. Your mouth is going to be occupied, so you can't breathe through it, right? And you're breathing through your nose. But as Kristen Guilleminault says, there's this very short period of time after birth where there is swelling in the turbinate proportionate to the size of the airway, with there's a lot of flow limitation that the infant overcomes very, very quickly, unless there's some kind of inflammatory situation, let's say meconium, they take it in, and then that kid's in trouble. And so
Mm.
then they're in the NICU, or they're born prematurely where there's not enough surfactant in the lungs. And there are all these factors that affect breathing, and those kids are in trouble. And in the past, they would die. Now we have the NICU and sophistications and being able to get them through that hump, if you will.
Yeah.
But it's still infantile. And then with that, you cannot separate the neurology, is the function of the tongue. You have that hooker reflex. So the tongue is involved in feeding and dilating the airway. That's a very primitive reflex, the cardinal reflexes, that gets replaced within those first several months. So there are benchmarks in neurology that the cerebral language pathologists look for in that first year of life that a child must overcome. And our modern environment, without recognizing, oftentimes interferes with that, whether it's a binky or bottle feeding or all these other things that we could talk about. But it affects how the diaphragmatic intercostal accessory muscle function that changes the way we breathe and compensates. It starts putting us down this spiral. And then
Mm.
over time, as the brain develops, you have a mature swallow, you have a masticatory pattern, that doesn't replace it, but adds on top of that neurology, those central pattern generators, as Kristen Gumino would talk about. So there's a lot of misunderstanding because in dentists, we're not trained, right, in this per se. We don't really get that much into it. Sleep and language pathologists know a lot about this, but they didn't really think too much about the airway because they were just thinking more about speech and swallowing. Now they understand
Yeah,
integral to the airway. So
yeah.
they're really very well trained in that regard. But this is what we talk about, the neurology that changes over time. And then about 3 to 4 months after you're born, from being obligate nasal breathers, you start having laryngeal descent that destabilizes the airway in preparation for us to have language. And so
That's
the
us
brain,
leaving the Garden of Eden, isn't it?
what's that?
That's us leaving the Garden of Eden.
Yeah, and starting to
Standing
talk.
up, 2 feet, being able to talk, communicate, the things that took us out of our more primitive nature and made us the humans that we are.
Right. The Great Leap Forward, as Terrence Davidson from SDSU wrote about as otolaryngology. But
Okay.
we're not getting into the weeds any further in the neurology. Let's talk about
Okay.
what do we do with that child that comes in. Mom brings a child in who is 4 years old and knows that the kid's in trouble. And tell me a little bit about how you see that child and what you do, and let's make it more clinical and practical and in your philosophy.
All right. Well, I mean, the structure, function, behavior paradigm rules really in my assessment and treatment planning. I want to see where the anatomical limitations are and if there's anything that we can do about them. I want to see where, all right, well, let's say the neurology has gone awry, and if there's anything that we can do about that. And of course, we look for the habits that are compensations that, with their own downstream effects, where we can return them to, well, let's continue that metaphor to the garden, right? From the anatomical point of view, we want to use, we say, the
Okay, let me jump in.
anthropologic
Let me
standard.
jump in. Okay, let me give you the scenario. Okay, before you go on.
All right, but
And let me give you the scenario. Okay,
okay,
so the kid, mom comes in, says recurrent earaches, bedwetting, um, uh, doesn't want to fall asleep, wakes up with night terrors, and um, she says, what do we do about it? What are the principles you use in addressing that? Because you're kind of getting some
right.
details about structure, function, and behavior, but let's make it practical. What's the first thing that you want to do for that kid? And
Well,
then
all right. So what I was going, because that I do use that that format for thinking and planning. I set my goals for structure, function, behavior, but the things that I choose almost always depend upon how much distress the child is in.
yes,
So, there can be simple anatomic problems. I mean, some people do have underdeveloped jaws, but no other medical symptoms. They may be just lucky. But, usually there are issues in all three domains. I mean, the example that you gave is so common, right? That they're not having good sleep, they're not getting good rest, they're as miserable as we would be if we didn't get a good night's sleep, except they've been doing it day after night, year after year for their young lives. And the amount of physical distress, psychological distress, neurologic distress, if we want to say it that way, um, the more they are struggling, the more aggressive I want to be. The less they're struggling, what I try to do is just realign the trajectory of their physiology. In other words, Hey, we may have a palate that's somewhat collapsed, a tongue that's low, but if they're not in that much distress, then I can work on the behavioral aspects, start doing myofunctional training, get the tongue on the palate, maybe give the palate a little bit of a boost with, a tongue surrogate like an ALF or bent wire or something like that, myobrace, any of those that sort of take over what normal or optimal physiology should be.
Okay, so
But
that,
but
so,
when they're struggling like that, I don't want to wait for natural biology to take over again. I want to get them back to where they should be. The
okay,
amount
so
of
let me jump in
damage that's
right
been
there.
incurred, right? All
That's
right, go ahead.
yeah. So let's just go back to the underpinnings of the Airway mini residency that we talked about. Let's talk about principle number one, um, are the medical indications for why we do dental intervention. Everything that you
Yeah,
talked about, what I want, I guess the point I'm trying to make and focus on, and what I see is completely missed and in most of these weekend courses and all that, because they're talking about the way you just talked about, and to some extent. But I'm just gonna mention, and you and I've talked about this. It's our tendency to forget this as dental professionals, but I'm gonna underscore the primary pillar is the medical indications for why we do dental intervention. So we have to measure that quantitatively and we can't just say they're in distress, but for sure, the
oh
thing
yeah,
that
no, we try to justify it as objectively as we can. Yeah,
quantitatively and qualitatively, we won't get
right,
into the details, but once we've got
right,
that, number one job is to get the kid out of distress.
right.
Everything else that we talk about is really growth guidance. After the car accident, you could start fixing the fenders and all that. But the first thing we want to do is put tourniquets on and get people to the hospital, so to speak, stabilize, right? And
Yeah.
so it is that serious when you start seeing some of these kiddos that are really struggling with hypoxia. It's just not recognized. So that leads us to um, the let's talk about palatal expansion, especially you as an orthodontist. I think the orthodontist, there
Wait,
are a lot of
wait, I'm going to send you a sign here. Watch this. That's our sign for heated agreements.
yes, yes. Exactly. Well, I know we agree on that, and
Yeah,
but because our audience may not understand, I think that's the key principle is you must stabilize their breathing. The heck with the palate, the crossbite, the tooth decay, and all those other things that go along with an earring. We got to get them to breathe right away.
yeah.
So with that, we know that there have been many arguments within the orthodontic specialty and orthodontists, as we call the general dentists that do ortho and all that,
Yeah.
on rapid, semi-rapid, how much do you expand, to what level do you expand,
What intermolar width? Yeah.
yeah, and it's too dangerous to do it too fast, and then you do it too slow. So I want to get into that detailed discussion right now about that, but I want you first, as an orthodontist, to comment about your protocol in palatal expansion.
And in palatal expansion, because I was going to say, in line with that thinking, I sometimes I don't even start with the techniques and the palatal expansion. Yes, if I'm going to get a kid out of trouble, I want to do it fairly rapidly. I mean, if I think about a child and the way they're suffering at night because they have flow limitation and often apnea, but not, not as much as adults, right? I mean, I think their neurology is pretty well adapted to avoid true apnea. But if they're struggling at night, I don't want to sit around for a year before I can develop the palate. I want to get that thing open, tongue space, get the tongue out of the throat, get it forward in the face, make room for the tongue. To tell you the truth, I'm not personally, I don't jump on relieving tongue ties so fast anymore. I really want to first create a good bed for it, and secondly, make sure the child is prepared properly for a tongue tie before I would do a release. But sometimes there are fascial restrictions that are making it hard for them. Sometimes the unresolved reflexes, and those are behavioral things. Teaching a kid how to blow their nose, wash their nose, can be a very big help. I mean, if their tonsils and adenoids are so swollen that they're corking up the airway, often it's because those organs are trying to deal with unfiltered air. And
Okay,
just getting
so
the nose open can relieve, if they're young enough and the organs are not scarified enough, they can relieve can relieve breathing and establish nasal breathing right from the beginning. That doesn't require splitting the palate
okay, so let me.
necessarily.
Okay,
But
so
yeah, I'll start with that a lot.
I'll just say that so when I'm screening my kids, okay, and let me give you the scenario that I see
Yeah,
typically. Because I think you and I have a slightly different protocol, and that's okay, but I'll just share mine.
yeah,
That when I see time and again, and by the way, this is based on the IRB clinical study that I did with Uma Katwa. We're going to publish it.
yeah,
Uh, so I'm not just making this up. I'm looking at a very data-driven approach, and that is where a child comes in, as David Gozal would say, snore plus, meaning that if the child snores plus there's at least one other symptom, it could be bedwetting, it could be earaches, it could be irritability, it could be hyperactivity, it could be any of a number of things, that calls for something not to ignore, that we need a high level of diligence to find out what's going on. So a pediatric sleep questionnaire, which there are many versions of it, I use the Shervin, but there's also the SDIS and variations of them that have been validated. When I have that data and I've got the check loud breathing, snoring or whatever the case that the parent will do
yeah,
to go along with high resolution pulse oximetry data that may show, and you alluded to this, may show a very low apnea hypopnea index of 1 or 0. So just as an aside, we know that the American Academy of Sleep Medicine recognizes that the apnea hypopnea number should be less than 1. Let's call it
for
1,
kids.
right? For kids.
Yeah.
If it's 2, it's technically sleep apnea. But I
Mhm.
go way beyond looking at even that and more at the autonomic nervous system response, which is mostly what I'm looking for. Um, when a kid is having a lot of apneas, and we do see that, like my son, that's elevated, that's
Right,
like danger, Will Robinson, jump on this. This is something you really need to get. But a lot of
right,
kids who, quote unquote, don't have sleep apnea have very many non-hypoxic events that are not recognized for what they are. And
right.
so I was talking to Craig Pickerel, from patient safety this morning, because we were talking about the data from our study that we're looking to publish about this, and how Uma Katwa kind of is having a hard time because he's used to seeing apneas and hypopneas, not so much the autonomic nervous system
Right.
on its own. But we see these kids, and so what I do is the child, when they come in, we're putting on and getting their blood pressure, and we're getting, most importantly, their heart rate. And so as a baseline, let's just say their heart rate is at 80 beats per minute. Let's say they're 5 years old, 6 years old, normal, that would be within normal limits. And then you do high resolution pulse oximetry and you get 3, 4, or 5 nights of data because we
And
want
they
all the data.
spike.
And you look at their heart rate is at or above all night long. You wouldn't know it unless you actually had that data. to know how much in distress that they are. So that's what I call distress.
Yeah,
And how I
I
know
agree.
is that when you do palate expansion, because if you subjectively look at their palate and say, oh, it's wide enough, I'm gonna teach them how to blow their nose. You're gonna miss this. I see it time and again. Those are all things that are adjuncts that we look at. But when I see that, it's telling me I need to take care of this right away, get them out of distress. And how do we do that? It's rapid palate expansion. And why does that work? I don't expand. People say, well, what do you expand to? I don't expand to a number. I expand to physiology, physiologic decreasing physiologic distress that is measurable. So I will uh, have them turn twice a day for a week, 1 to 2 weeks, and then have them back. And what it does is when you open that midline suture, it's got two major effects. One, and it has very little to do with tongue space. I mean, that's an indirect effect, and there's a lot of confusion about that. It's the palatal expansion that has very little to do with the palate and more to do with the nasal fossa. And what it does is it has a physiologic effect when you decrease nasal resistance from popping that suture open. There's an autonomic nervous system effect that calms that autonomic nervous system. You see that heart rate drop. And it's not a function of the size of how wide that suture is. So that's the first thing that I will do. And then, of course, you are also creating more space, but you've already occupied a lot of that tongue space with the RPE, right? So you counterintuitively go, wow, I'm taking up tongue space, but I'm creating space by making it wider. It's more the physiology that we see, and that's very well documented. The angle of the cartilage of the nasal valve opens up, less flow resistance, autonomic nervous system goes to where it wants to be, which is efficiency and energy, right? Efficiency to go into parasympathetic coherence. So I find that that will happen within 2 to 4 weeks, maybe within days. And then I take my foot off the pedal. At that point, we're doing neti pot, they're blowing their nose, they're doing all those types of things. I don't care if the palate is quite wide, because that will relapse very, very quickly. Once we deal with that flow limitation, then I will let them relapse a little bit, possibly, and then slow everything down. And then, so that's phase one. And then we get into phase two, which is growth guidance, which can take many, many years. And there are many, many tools in dealing with that, some of which you already talked about. But the point I'm trying to make here, Barry, is that we've got to be more physiologic in understanding flow limitation and the effect that and the purpose of the palatal expander and in our protocol. And then we could get into tongue tie revisions and all that. And I'm in agreement with you. I think it's a mistake to revise the tongue on a 3, 4, 5-year-old before it's been repatterned, because it could actually make the breathing worse and sleep worse at night. Now, exception is an infant. An infant, you could go ahead and release that right away so that they can latch, because it's not the fast
Right.
tie is not so complex, and that's its own discussion. But I
Yeah,
just
I
wanted to
agree.
throw that out there and tell me what you think about that, what I just said.
Yeah, I suppose that I take a little more circumspect view in the beginning because I not only want to prove to myself, I often want to prove to the parent that the kid's in distress. And some know it, of course. They bring their kids to us because they know the child is suffering. But still, I want to document what those medical conditions are. So I've recently started a program that I call the Foundations Program. It's it's trial diagnostics more than anything else. I'll spend, unless it's I mean, sometimes it's very clear that the kid needs to get the expansion right away, but I'll spend 3 months I don't use the high res pulse oximeter anymore. I just can't keep it on the kid's fingers. I've been using the sleep image cardiopulmonary coupling
Mhm.
device. There's a group that manages it for me. I don't have to administer those things anymore. The Empower group, trained by Robert Thomas, they administer the ring for a good month, and I'm working on establishing a protocol where the family can keep it for 2, 3, 4 months. And then we can do these trial diagnostics. We get a baseline, we do some nasal cleaning and clearing, maybe have them wear the Maya brace, see if there's any relief, and measure it. Because I agree with you that the first place to look is during sleep, because that's when we're the most susceptible, to where our compensations don't work so well. Um, and
So let
and
me,
even do rapid palatal expansion and then measure it again.
yeah, so let me,
So
so just in closing this, because we're coming up, I'll just make a couple of comments on it and how really think about the intellectual part of the mini residency. It's not like saying this is the way it's got to be. Everyone's kind of working their way through. So what I like about
yeah,
your protocol is that you're actually using a quantitative metric of some sort.
yeah,
For one, will use high resolution pulse oximetry because I believe, and I believe the SQI sleep image is great. Those are all great adjuncts. Those are great ways of measuring, if you will. And obviously, we know we interviewed Robert Thomas early in Spreecast, if you remember way
right.
back when,
That's
talking
right.
about it, when no one was even knowing what
Yeah,
about that. So I understand how it all works, but I think they're measuring slightly different things, but it's a metric, okay?
yeah,
So for me, I'm kind of like this restorative dentist that I am, as I would tell my residents at UCLA, and Rich would totally agree with it, is that we don't just give up on a technique like rubber dam. A lot of dentists that get out and they stop using rubber dam because it's very difficult. And I always say to my students and my residents, look, you'll only get good if you get through that learning curve to where you're not even thinking about it. Well, high resolution pulse oximetry is kind of
yeah,
the same thing. You
yeah.
can't get too
This whole
frustrated.
thing is like that.
Yeah, but you get really good at it. So I my
Yeah,
staff really trained on how to train the patient about it, how to stay on it, and it works really well for us. But I agree, there's a little bit of a learning curve. And like I said, I talked to Craig Pickerel this morning. So they're coming up with finishing their FDA approval where they're going to have the Bluetooth, where they have it on the forehead. That's
see,
coming up.
I'll jump all over that.
Yeah, and
Whatever,
that's
we need something that's
yes,
reliable, easy to
yes.
figure out what's going on for the kid.
Right,
Yeah,
right.
that'll be
And
great.
so slightly different way, but point is we're using a quantitative metric to tell us.
Yeah,
And interesting thing is, and I'm going to end on this so we can wrap things up. The interesting thing is that if I'm seeing two or three kids in that family, and the parent brings the one case, and I see this all the time, the one kid that's in distress, and then we end up screening the others. Oftentimes, the one that's not looking like they're doing great and they're sleeping well are in much greater distress
yeah,
physiologically. So you can't just qualitatively say that kid is in distress. So for me, when I say distress, it's not
yeah,
based on a qualitative assessment.
yeah.
Yes, that is a component, but it's looking at their
Right,
physiology because
right.
that individual, that kid that's maybe the firstborn, he's a pleaser, very high functioning, they're sleeping on their stomach where the other kid's sleeping on their back. So they
Mhm.
figured out a way of sleeping, but they're still having many more events than the kid that quote unquote is in distress. So I want us
Right.
to be cautious. And it's kind
I
of,
see that. I see parents they'll know which one they think is the worst. And that's their
right,
only experience. So
right.
the other ones aren't so bad, so they're not so bad. But they can be bad.
They can be, and
They
you gotta
can
be
be.
careful.
Yeah.
You can't say you've got high blood pressure, whereas you don't without using a sphygmomanometer, right? You
Yeah.
might be surprised. Yes, there are phenotype markers to be sure that we'll talk about in another podcast, but I wanted us to really have a little bit more of a practical clinical discussion to your great podcast last week with Rich, where you very aptly covered kind of the philosophy in kids being the best version of themselves, capping it off with the movie Wall-E and all that. But I think we talked a little bit about the practical concepts, which is in summary, um, get the kid out of distress first, and
Yes,
then growth guidance. And maybe one of the next podcasts we could talk about, well,
we
what
can
does
talk.
that mean, growth guidance? But
Yeah.
I wanted to wrap it up. I think we had a really good discussion. But with that said, let's follow our uh, podcast format. And Barry, I'm going to ask you, what is your learning um, moment of the week that you want to share? So
Oh boy. Every week has so many learning moments.
And it doesn't have to
It,
be on Airway, it could be on, uh, learn to maybe listen to the dog when he's scratching the door to let him
all
know.
right, all right. So if I can go outside, I've been reading a book by oh, I got to think of his name, the Israeli author who is a historian and looking at, because this is going to be appropriate to our title, looking at the way that humans have handled information and the way it has structured societies.
Sapiens?
And he talks about the nexus of information, where information comes together. And he distinguishes ways in which information can come together to illuminate the truth, and ways in which information can come together to create control. And that becomes the dichotomy that we're certainly going through it in this country. Many and frankly, in these next several years with AI coming together, this idea of truth versus order is a kind of a mind bending concept that I'm starting to look at things, at. So that was my
What's the name of
personal
the book?
nexus.
Oh, it's called Nexus. Interesting.
Yeah,
Yeah, I agree. My son Brendan and I have been talking about it because he's in that space, technology and AI.
yeah.
And I've been an early adopter of and use the various tools, and it is quite scary.
Yuval Harari, by the way, is the author's name.
U-
Harari.
Uval, okay.
Yuval Harari. This is the third book of his that I've read, and frankly, I don't read much out of professional
Yeah,
literature.
it sounds like I believe he wrote *Sapiens*.
He wrote about um, steel guns and
No, Germ Stealing. No,
no, that's Diamond.
that was
No, what?
Jared Diamond. That was
Yeah,
Jared.
yeah, yeah. No,
That was
I'll think of it. But
Yeah, yeah.
great writer.
I think he wrote Sapiens. Yeah, interesting.
Yep.
But yes, I think that's going to be something that we're really going to have to grapple with as a society of what is the truth. Like, for instance, if you use AI for references, and we know going through and writing our textbook, right, um, these various tools, whether it's Claude, ChatGPT, um, Perplexity, and et cetera, they can hallucinate. And what happens is you get lazy researchers that use a bibliography that then gets cited and it gets recycled. So misinformation gets recycled
Uh,
as truth. And I think that's going to be a challenge. I think there'll be some guidance. But anyway, with that said,
yep.
let's remind everybody about January, our uh,
AMR coming up.
AMR, the 3-day course of which is we reformatted to make it more clinical right away. I'm very excited about the format and glad that we'll be working together with Rich in helping our colleagues really learn more in a probably a better, easier way of understanding airway. So with that said, look forward to next week, Barry.
I look
I think,
forward to
oh,
it
you're going to
too.
be in Israel, so maybe
Oh yeah, yeah. I'll probably miss next week. Do you know that we have a interdisciplinary conference in Jerusalem? We are overbooked for a 340 seat auditorium.
nice.
A day and a half of lectures of all kinds. I'm going to be doing the keynote lecture, just giving this overall view and putting all the lectures in context. They are so excited about this integrative, collaborative, WHOLE, holistic tech,
Yeah.
approach to
I'm
healthcare.
I'm sorry that we couldn't work it out for me to be there. Maybe next year.
Next year.
Yeah, I know. I think that's exciting. So good luck with that,
Yeah,
Barry.
thank you.
And we'll talk to you when you get back. So maybe you could report to us on it. But thanks for another great session, and we'll stay in touch.
So happy to be here.
All right, take care.